Thanks for joining, everybody. As Marie said, this is part 2 of our E&M update series. If you didn't catch the first one, it will be posted on vitalware.com under our resources and then webinars. So make sure to catch that one because this is only half of the updates. So let's get started. Here's our disclaimer statement. This is just saying that this information is current at the time of this presentation, but we always advise that you refer to the most up-to-date resources and regulations at a regular date, at a later date. So here's our agenda, and today we're going to cover consultations and transfer of care, emergency department services, nursing facility services, home and resident services, and then throughout the presentation, I'm going to sprinkle in some scenarios and examples just to check our understanding of the guideline changes. So let's start with consultations and transfer of care. So changes in this area are pretty significant, and they were really made for consistency's sake and just to simplify the reporting of these services. In the presentation yesterday, Orders reviewed that all of the E&M changes that were made to decrease the administrative burden of documentation and coding, and to really just try to align CPT with CMS and to decrease the need for audits and just to decrease unnecessary documentation in the record that we don't need, because nobody likes extra documentation, especially the physicians. And they also want to make sure that the payment for the E&M is resource-based. So first, we will just talk about what a consultation is. A consultation is a type of evaluation and management service provided at the request of another physician or other qualified healthcare professional or appropriate source to recommend care for a specific condition or problem. You see this other qualified healthcare professional added in the guidelines everywhere. This is just to clarify that it does not have to be a physician providing the care. The CPT codebook defines qualified health professional as an individual who is qualified by education, training, and facility privileging when it's applicable to perform a professional service within his or her scope of practice and independently reports that professional service. So this is a distinct professional from clinical staff, which is a person who works under the supervision of a physician or a QHP. So consultation services are utilized across multiple healthcare settings. They can be utilized in the office and outpatient setting, inpatient observation setting, nursing facility setting, etc. There are differences of opinion between the AMA, which publishes the CPT book, and CMS here. CMS does not recognize consultation codes. The AMA feels that consultation services are typically considered difficult and time-consuming because the patient is not known to the provider. So they think that adds a level of complexity and intensity to providing the service. And then there's the additional time spent up writing the report and communicating to that treating physician. So they do feel that this distinguishment between the two types of codes are necessary. So there's really not an advantage to using the consultation codes for Medicare at this time because they do not recognize the consult codes. So know your payer and just know that, some payers, there are advantages to using these codes. The next bullet says that the consultant's opinion and any services that were ordered or performed must also be communicated by written report to the requesting physician, other qualified healthcare professional, or other appropriate source. And then, of course, that would be filed in the medical record. A consultation that is initiated by a patient or the patient's family and not at the request of the physician or other qualified healthcare professional or other appropriate source is not reported using a consultation code. So this, if a consultation is initiated by the family or the patient, then this would be reported, that physician would report it using other appropriate E&M services, such as the initial hospital or observation codes or the nursing facility codes. So again, the family member's request is not an appropriate source of a to use a consultation code. And then the last bullet here says that if the consult is mandated by a particular payer, then you should include modifier 32 with those services. So we've discussed what a consultation is. Transfer of care is different. So transfer of care occurs when a physician or other qualified professional providing management of the patient's problems relinquishes responsibility, and that care goes to another physician who agrees to take on that patient. So this is different than a consultation, and it doesn't matter. I'm not sure why I'm even telling you this, because this has been deleted. So you don't need to worry about what transfer of care is anymore. This was very confusing for many people, and a lot of times this was being coded incorrectly. So consultations and transfer of care codes were being mixed up. So that's why they have deleted the transfer of care definition and guidelines so that this will no longer be used. So now any services that constitute a transfer of care would be reported using the appropriate new or established patient codes for office, outpatient visits, or home and residence services in the initial hospital, inpatient, or observation care, or initial nursing facility care subsections. Okay, so I'm going to read this to you because when I initially read this, I actually had to read it a couple times for it to kind of click. And then I'll kind of go into it a little further afterwards. So if a consultation is performed in anticipation of or related to an admission by another physician or other qualified healthcare professional, and then the same consultant performs an encounter once the patient is admitted by the other physician or other qualified healthcare professional, report the consultant's inpatient encounter with the appropriate subsequent care codes, 99231, 99232, or 99233. This instruction applies whether the consultation occurred on the date of the admission or a date prior to the admission. It also applies for inpatient consultations reported with any appropriate code. And examples would be office or other outpatient visit or office or other outpatient consultation. So again, if a consult occurs prior to the admission of a patient, even if it's days before the admission, the next visit from that physician in the hospital would be coded using a subsequent care code, even though it's the first time that that consultant is seeing that patient since the patient's been admitted, as long as that visit is in regard to where they saw the patient for previously. So you would not use an initial visit code in this instance. So the lowest level straightforward office and inpatient consultation codes have been deleted to align with 4 levels of medical decision making. And if you watched the presentation yesterday, you see that they're really trying to be consistent across the board in all sections with having 4 levels of medical decision making. Just to, it's really confusing when some sections you have more, some sections you only have 4. So they're really trying to streamline it across the board. So in 2022, you have 99241, which is a straightforward medical decision making for a problem that's self-limited or minor. Then you have 99242, which is again, straightforward medical decision making, but for a problem that is low severity. So in order to be consistent across the board, with only one code representing each level of medical decision making, they are deleting the 99241. And the 99241 is for your office consultation. And then you'll see they also deleted the 99251, which is your inpatient consultation. So that one was also deleted. And then you'll see later that more codes were revised or deleted to line up with the 4 levels to make things just very straightforward and less confusing across the board. So the descriptions to the office and outpatient and inpatient consultation codes have undergone revisions for 2023 to reflect the extra work of the consultation. And again, just to simplify things. So I only included the first level here to show the changes because the changes that were made to the descriptors for all of the office and outpatient consultation codes, they really were the same thing, pretty much, the same types of changes. So just to not bore you with 1,000 slides of the different codes, I just have the lowest level here so we can just talk about the changes. The revised consult codes, you'll see here, they do not require specific elements of a history and physical. They only require a medically appropriate history or exam for the patient's medical condition and situation. So, for example, one of the AMA physicians said that she's an OBGYN. She doesn't necessarily need to look in the patient's ears when she is doing an exam. So this is really just putting the extent of the exam back into the physician's hands so they can make the call. So they can make the call if what extent they need that history to be to, that exam to be to. So a reminder that for these codes, either medical decision-making or time can be used to find the appropriate code. And you'll see that time has also changed for this code. So in 2022, it is 30 minutes, and in 2023, it is 20 minutes. And then in a few slides, we're going to go over the other time changes for these codes. They also just kind of took out the fluff. So this sentence about counseling and coordination of care with other physicians, other qualified healthcare professionals, et cetera, it wasn't really adding anything meaningful to the definition. So, I'm a big fan of just getting to the point with what you want to say. So they took that out just to simplify the description of the code. Okay, so here is your inpatient or observation consultation code 99252. Again, this is only the lowest level just to show the changes again. As you probably heard in the previous presentation, observation codes have been deleted and they're now covered. They've been merged with the inpatient codes. So the code descriptors now cover both inpatient and observation codes, as you can see here. That was changed. And then the other changes are the same types of revisions as the office and outpatient codes. And you'll notice that the time has also changed for this one from 40 minutes to 35 minutes. Okay, so along with the code descriptor changes, there's also been considerable changes in the time thresholds for the consultation codes. So here are your office and outpatient consult codes. And when using total time on the date of the encounter for your code selection, you want to make sure that at least 20 minutes has been met or exceeded if you're going to use time as a code selector. You can see how the time thresholds have changed. And so let's see, for 99242, it is now 20 minutes. It used to be 30. 99243, it's now 30. It previously was 40. 99244 is now 40. It was previously 60. 99245 is now 55. It was previously 80. I've also included the prolonged services code here. For a deeper dive on prolonged services, you can check out the presentation that was done, part 1 E&M changes on the VitalWare website. Ardith did a really good job of providing like tables that really compare CPT versus CMS prolonged services codes because it can get really confusing. So please check that out if you want a deeper dive on prolonged services. So here are our inpatient and observation consult codes. And when using total time on the date of the encounter for code selection, at least 35 minutes must be met or exceeded here. So we have 99252 is now 35 minutes. It was previously 40. 99253 is 45 minutes. It was previously 55. 99254 is now 60 minutes, previously 80. And then 99255 is 80 minutes, previously 110. And then I also added the prolonged visit code here, 99418, and that's 95 minutes or longer. So when the total time exceeds the time identified by the highest level code available by 15 minutes, that's when you can use a prolonged service code in addition to the primary E&M code. So in this table, just to remember, you need to code the highest level E&M code along with your prolonged services code. This table shows you the prolonged service code in that first column, which E&M code to report with it. These are only the consult codes. And then which E&M code you cannot report with that prolonged service code. And then it shows you the amount of time that needs to be met in order to be able to report it. So again, it's 15 minutes past the longest E&M level code. All right, so here is scenario 1. An 83-year-old woman presents to the ER with atypical chest pain. The hospitalist consults a cardiologist, and the cardiologist sees the patient for a consultation prior to admission. The cardiologist orders a stress myocardial perfusion imaging study. The hospitalist admits the patient, and then after admission, the cardiologist sees the patient for a second time. How should the consultation that took place after admission be coded? A, with the appropriate inpatient or observation subsequent care code, 99231, 99232, or 99233. B, with the appropriate inpatient or observation consultation for a new or established patient code, 99252 through 99255. I'll give you a minute to just kind of read that over again, because I know sometimes whenever someone's talking, it's hard to really concentrate. All right, so the answer here is with the appropriate inpatient or observation subsequent care code, 99231, 99232, or 99233. Because the guideline states if a consultation is performed in anticipation of or related to an admission by another physician, then the same consultant performs an encounter once the patient is admitted by the other physician. Report the consultant's inpatient encounter with the appropriate subsequent care code. This instruction applies whether the consultation occurred on the date of the admission or a date prior to the admission. So good job if you got it right. Here is scenario 2. The same 83-year-old woman undergoes a stress myocardial perfusion imaging study. The perfusion images reveal an anteropical fixed defect with some reversibility. The cardiologist recommends a cardiac catheterization, but the patient and family requests a consultation and a second opinion from another physician before making a decision to proceed. How would the consultation with the second cardiologist be coded? A, using a code from the inpatient or observation consultation codes, 99252 through 99255. B, using a code from the initial inpatient or observation care services codes, 99221 through 99223. So remember, these are your initial hospital inpatient or observation care per day for the evaluation and management of a patient. So I'll give y'all a minute to read that. All right, and the answer here would be B, using a code from the initial inpatient or observation care services codes 99221 or not through 99223, because the consultation was at the request of the family, not the physician. It would not be appropriate to use the inpatient or observation consultation codes in range 99252 through 99255. All right, so now we're going to talk about emergency department services. And again, these changes were made as part of the effort to standardize reporting of the guidelines for all the codes in the E&M sections. The goal of these specific changes were to eliminate the complexity that followed the 2021 E&M revisions, in which there were two different sets of guidelines for different E&M services. So they're really just trying to streamline things here. So there's not as many changes in the ER section for E&M codes, but I'm going to go over a few guidelines that maintained. So they maintain the existing principle that time is not a descriptive component for the emergency department levels of E&M services, because emergency department services are typically provided on a variable intensity basis, often involving multiple encounters by the same physician with several patients over an extended period of time. So time is not a factor in code selection for emergency department services. They also maintain the existing principle that there's no distinction between a new and established patient in the ED. Guidelines also clarify that these codes may be used by physicians other than just the ED staff. So here is another clarification to an older guideline, a guideline that already existed. For critical care services provided in the emergency department, see critical care guidelines in 99291, 99292, which are your critical care codes. Critical care and emergency department services may both be reported on the same day when, after completion of the emergency department service, the condition of the patient changes and critical care services are provided. So the new guideline is more specific, because in previous guidance, they had stated that critical care services could be reported with other E&M services, but they didn't specify ED services in particular. So this is just clarifying that this is allowed for ED services as well. All right, so there's a big change here. They modified the descriptors to conform with office visits. So now 99281 is for ER encounters where a physician may not be present. So an example of this would be simple wound care, suture removal. The AMA said they were hearing of more and more instances of this where a code for this was really needed in the ER. So this is similar to how code 99211 for an office or outpatient visit is a staff supervision code that doesn't require the presence of a physician. So now this lowest level ER code 99281 is similar to that. It was previously straightforward, but now straightforward has moved to 99282, so which used to be low MDM. So if you look above each little box, it will say what it is now, and then under tells you what it was previously. So this can definitely get confusing. So if we move up the stairs here, prior to 2023, one of the requirements used to select both codes 99283 and 99284 was a moderate level of medical decision making, which definitely created some complexity when differentiating between the two codes. So now you see that 99283 is a low level and 99284 has stayed a moderate level. The moderate and high level, the two highest levels here, have no change. So this is a pretty substantial change that you definitely want to pay attention to. So here's the lowest level that for an ER visit that doesn't require the presence of the physician or the QHP. I just want to show you the description revisions here. They took out the 3 components of the history here, and again, and because the physician is not seeing the patient, so there's no exam here. And then they also took out the counseling and coordination, that sentence. And then they added in the statement that this visit may not require the presence of a physician or other qualified healthcare professional. So here is 99282, which is your straightforward ER visit. And this is the one that used to be low to moderate severity, and now it's straightforward. And again, same thing with the history piece taken out, the counseling piece taken out. And again, time cannot be used here for code selection for ER visits. And then here is 99283, which is your low-level ER visit. You can see that it was previously moderate and now it's low, and same types of changes here. So here is our next scenario. A 20-year-old male was biking and collided into another biker. He fell off of his bike onto the cement. He presents to the ED with several minor lacerations on his arms and legs, but no other complaints of pain. The nurse examines the lacerations and determines that simple wound care is warranted, and this patient does not require an examination by a physician. Which code should be used? A, code 99211, office or other outpatient visit for the evaluation and management of an established patient that may not require the presence of a physician or other qualified healthcare professional. B, code 99282, emergency department visit for the evaluation and management of a patient, which requires a medically appropriate history and exam and straightforward medical decision-making. Or C, code 99281, emergency department visit for the evaluation and management of a patient that may not require the presence of a physician or other qualified healthcare professional. So this little girl in the picture looks really confused, but it's really not that confusing because the doctor's not seeing the patient. So we know that it has to be C, code 99281, which is the emergency department visit for the evaluation management of a patient that may not require the presence of a physician or other qualified healthcare professional. Okay. So now let's talk about nursing facility services. Significant changes have been made to the nursing facility services subsection of the E&M section. Guidelines throughout this section have undergone extensive revision and clarification. So remember that the codes in this section are used to report E&M services provided to patients who are in nursing facilities and skilled nursing facilities, including services to patients in psychiatric residential treatment centers and immediate care facilities for individuals with intellectual disabilities. There's also other regulations pertaining to the care of nursing facility residents that govern the nature and minimum frequency of assessments and visits. So you also want to make sure to take a look at these regulations and who's allowed to perform the initial comprehensive visit and things like that. Take that into consideration. Sometimes the guidelines don't fully cover all your bases. All right, let's see. So here are some overall guidelines and things to consider when using codes in this section. To report these services accurately with the correct codes, consider the following. Types of care, such as skilled nursing and nursing facility care, are reported with the same codes. So it doesn't matter if the patient is in a regular nursing facility or a SNF, you're using the same codes for both. Place of service codes should be reported to specify the type of facility and care where the service is rendered. And there may be variations in payer policies about reporting nursing facility codes. So they may have additional information and requirements. So you definitely want to keep that into consideration whenever you're coding. Nursing facility services are performed by a principal physician or other QHP overseeing the care of the patient in the facility. So the principal physician is also sometimes referred to as the admitting physician. And that's really the physician who oversees the patient's care, as opposed to those other physicians or QHPs who give specialty care. Additional services can be performed by physicians or other QHPs as specialists performing consultations or concurrent care. And then you can also use modifiers to identify the role of the individual performing the service, because typically there are other physicians or other QHPs providing care along with the attending physician. So modifier AI, which is principal physician of the record, may be required to identify the principal physician for the payer. So when selecting a level of medical decision-making for nursing facility services, the number and complexity of problems addressed at the encounter is considered. So just to go over what problems addressed means again, a problem is addressed or managed when it is evaluated and treated at the encounter by the physician reporting the service. So this includes consideration of further testing, even if that testing is not carried out after doing like a risk-benefit analysis, or if it's not carried out due to patient choice. Notation in the patient's medical record that another professional is managing the problem without an additional assessment from that principal physician does not qualify as being addressed or being managed by that physician and should not be reported. So on high-level medical decision-making types specific to initial nursing facility care, they've added multiple morbidities requiring intensive management in the column that addresses the number and complexity of problems addressed. And this is a set of conditions, syndromes, or functional impairments that are likely to require frequent medication changes or other treatment changes and or reevaluations. The patient is at significant risk of worsening medical, including behavioral status, and risk for readmission to the hospital. So just to note, this has been added only for nursing facility services at this time. And here are a few more guidelines. So the initial nursing facility care codes 99304, 99305, and 99306 can only be used once per admission per physician, regardless how long the patient is there. So patients there 2 months, that initial care code can only be used once in those 2 months. The next bullet is the initial code can be used if the physician or QHP and no one in their exact specialty in their group practice has seen the patient during their stay. When advanced practice nurses or PAs and PAs are working with physicians, they are considered to be part of the group. So if the PA sees the patient and then the physician sees the patient after, the physician cannot use an initial service code because the PA has already seen the patient, okay? Next bullet says that when the services at a separate site are reported and the initial nursing facility care service is a consultation service provided by the same physician or QHP and reported on the same date, codes 99252 through 99255 and 99304 through 99306 should not be reported. The consultant should report codes in the code range 99307 through 99310, which are your subsequent nursing facility care codes for the second service on the same date. And then next, if initial services are rendered by other physicians or QHPs, not the principal physician or QHP, who are performing consultations, these initial services may be reported using a code from the code range 99252 through 99255, which are your inpatient observation consultation codes, are 99304 through 99306, which are your initial nursing facility services codes. And then finally, use a subsequent visit when the principal physician's team member performs care before the required comprehensive assessment. So here is 99304, which is your initial nursing facility care code. Again, I'm only including the lowest level here to show the changes because for all of the other levels, the changes are similar. So for the nursing facility care codes, they again took out the requirement of having 3 key components to the exam. So now the physician, it just requires a medically appropriate history now on your nursing facility care codes. They also took out the counseling and coordination sentence, and then they changed from, talking about the time spent at the bedside and on the patient's facility floor or unit. They changed that to the total time on the date of the encounter. For this one, let's see. For this one, the time did not change. So also just a note about these initial nursing facility care codes. Transitions between a skilled nursing facility level of care and a nursing facility level of care do not constitute a new stay. So after the transition, an initial nursing facility care code would not be used again. So if your patient is in a nursing facility and then they need a higher level of care and they transfer to the SNF unit, or the SNF facility, you would not do another initial nursing facility care code. All right. So again, times did not change on these codes. There are also prolonged services codes that can be used with these codes. So now we're going to look at 99307. And this is your subsequent nursing facility code. This is your straightforward lowest level again. And I'm just showing the changes again right here. Times did not change for these subsequent, for the subsequent code, both 10 minutes, same types of changes as I reviewed previously. Also, when using time for these codes, you are able to use prolonged services codes for these. So also in this section, code 99318 has been deleted. This is the annual nursing facility assessment code. This existing service will be reported through the subsequent nursing facility care services codes, which is the range 99307 through 99310. Okay, so now we're going to talk about the nursing facility discharge management codes. And these codes are used to report the total duration of time spent by a physician or other QHP for the final nursing facility discharge of a patient. So total time spent on discharge is counted, even if the time spent is not continuous. The services that count toward this time are listed here. The final exam, discussion of nursing facility stay, instructions for continuing care, even if you're giving those instructions to a caregiver, preparation of discharge records, prescriptions, referral forms. So interestingly enough, these services can be performed prior to the discharge date. So this is in contrast to your inpatient and observation services, which require that discharge services must be performed on the discharge date. These discharge services can be performed prior to the discharge date. However, they do require a face-to-face encounter with the patient and or the family or a caregiver. So here are some minor revisions that have been made to the nursing facility discharge management codes. The they added in total time on the date of the encounter to clarify. And again, it doesn't have to be on the discharge date, just the date you have to have the face-to-face encounter in order to be able to count that time. So here is our scenario. A 77-year-old female patient is in stable condition and recovering from a stroke in a skilled nursing facility. An annual nursing facility assessment is conducted and takes about 30 minutes. The results of the assessment are discussed with the patient's family. How should this be coded? A, using the annual nursing facility assessment code 99318, which is evaluation and management of a patient involving an annual nursing facility assessment. B, using a subsequent nursing facility care services code in the range 99307 through 99310. And I'll give y'all a second. So the answer is B, using a subsequent nursing facility care services code in the range 99307 through 99310. Annual nursing facility assessment code 99318 has been deleted effective January 1st, 2023, and the subsequent nursing facility care services codes should be used instead. So now we are going to talk about home and resident services. Again, changes in this section are also related to the shift to standardize the guidelines and the reporting needs in the E&M section. So the domiciliary, if that's how you pronounce it, our rest home CPT codes 99334 through 99340 were deleted and merged with the existing home visit CPT codes, which is a good thing because I don't think a lot of people really even understood what a domiciliary home was. So I think a few people were in the same boat as me. The home visit codes have a new title. They added in resident services. So these codes represent a private residence, temporary lodging, or a short-term accommodation, which could be a hotel, a campground, etc. Also, additional clarity has been provided on when these codes can be used. So these codes can be used when the residence is an assisted living facility, a group home that is not licensed as an intermediate care facility for individuals with intellectual disabilities. Because remember, in those cases, that would be your nursing facility codes that you would use. Custodial care facility or residential substance abuse treatment facility. So here we see the lowest level home and resident services code 99341. This is for a new patient, straightforward. And same types of changes here, only a medical appropriate history needs to be required here, counseling, coordination taken out. And then just notice here that the times have changed. So previously it was 20 minutes and now it is 15 minutes. So I'll show you some more with that on the next slide. So these are your new patient home and resident service codes, and these are the time changes. Remember that when you're using time for these codes, to choose a level, you cannot count your travel time in your time here. So just something to keep in mind. So 99341 is now 15. It was previously 20. The rest, 99342 through 99345, there was no change to these times. And then for prolonged services, code 99417 may be used, or a G code could be used for Medicare. Also, you might notice that 99343 is missing here. We're going to talk about that in the next slide. So 99343 has been deleted because it was a duplicate MDM level due patient code. It's just as a result of the consolidation process. They did not want duplicates like this, so they only wanted the 4 levels. So since 2 of them were moderate level, they took out 1 of them so that there was only 1 per level. So here is 99347, which is your established patient straightforward home and resident services code. Same types of changes here. The time did change here. So it went from 15 minutes to 20 minutes. And I will show the additional time changes on the next slide. Okay, so again, these are your established patient home and resident service codes. And we have 99347, which is now 20. It was previously 15. 99348, which is now 30. It was previously 25. And then 99349 and 99350 have no changes, continue to be 40 and 60. Also, for prolonged services, code 99417 or the G code could be used for Medicare. So here are the new patient codes for that were under the domiciliary or rest home visit code section and that were deleted. And what I have here is I have the deleted code and then I have the code that would be used in its place on the right side. So one thing to take note of on that first code 99324, it does have a different time amount. So that one's 15 minutes and the old one was 20 minutes. So just something to be aware of. Here is a continuation of the deleted codes and appropriate replacements. And again, on 99326, the replacement code has a different time. And in this case, the time is actually longer. It's 60 minutes rather than 45 minutes. So definitely something you want to be aware of if you're using time to select your code. And then here are the deleted established patient codes. And then here are their replacements. And then again, on the first one, I have it highlighted. It is a time change, 20 minutes now instead of 15 minutes. And then here are the rest of those codes. And then here is our next scenario. So how would a domiciliary or rest home visit for the evaluation and management of an established patient be coded when 65 minutes were spent with the patient and total time is being used for code selection? A, using code 99350, which is your home or residence visit for the evaluation and management of an established patient, which requires a medically appropriate H&P and a high level of medical decision-making, and total time is 60 minutes here. B, using code 99344, which is a home or residence visit for the evaluation and management of a new patient, and total time would be 60 minutes here. And then, or C, using code 99337, which is the domiciliary or rest home visit for the evaluation and management of an established patient. And then time here is 60 minutes. So I'll give you a minute to look over that one. All right, so the answer here is using code 99350, home or residence visit for the evaluation and management of an established patient. And so the patient was established, so we would not use 99344 because this is the new patient code. And then code 99337 is the domiciliary or rest home code, and that is expired January 1st, 2023. So we would not be able to use that code. I see a lot of people getting the answer right, so that's good. All right, this brings me to the end of my presentation. Lots of good resources here, so check them out if you need like a deeper dive or explanations for these things. I would say that the E&M CPT companion was really helpful. I don't think I have the final rule tagged here, but that is also a really good resource. I know that Ardith had that tagged in her resources in her presentation. So definitely check that out. And then for those of you who are new here, I just want to take 1 minute to introduce VitalWare by Health Catalyst. We offer products to assist with your revenue cycle processes, and we were awarded first in class for our ChargeMaster product for 4 years in a row. So check out vitalware.com for more information. And again, this presentation or this presentation will be on vitalware.com under resources and then webinars if you want to check that out. All right.
Do you want to do any QA, Mickey?
I can look and see. Let's see. Looks like we have a few. So the first one says, is observation still considered an outpatient service? Yes, observation is still considered outpatient. Let's see. And then there's some more description in that question. I'm gonna actually type that one out because it gets a little sticky. So let's see. So this one says, is there an E&M service to bill encounter for filling out forms like a driver's test form after injury, not work disability related? Is there an E&M service to bill encounter for filling out forms like a driver's test? I'm gonna have to do some research on that and get back to you. I also have Ardith here, who is my coworker. So if Ardith, if you have any responses, please jump in. Let's see. So this next question says, why use subsequent? We get paid on initial, which is what it is, a first time seeing the patient. I'm not sure what this is referring to. This may be referring to how I said that if the consultant sees the patient outside of the admission, like prior to the admission, then they would use the subsequent code when they see them in the hospital. That is just a change that was made. I'm not sure if it really makes sense, but that is the change. So let's see. It says, so was the consult billed prior to them being admitted to the hospital? And was the outpatient consult billed then the subsequent billed when they get to the hospital? Yes. So the consult would have been billed prior to them being admitted to the hospital. Would place of service still stay the same? Observation 123, inpatient 122. Ardith, do you know the answer to that?
I'm sorry, so. what was the
says,
question?
Would place of service still stay the same?
Yes, there's no changes to the place of service. And okay. The reason why I was asking you to repeat that is there are CPT codes for doing work disability forms and paperwork.
Oh.
And those are in the 99455, 99456. But they are in the E&M section, kind of toward the back of the book. They're just not based on time or medical decision making. So that was not part of the webinar today.
Okay, gotcha. So that is in response to the question, is there an E&M service to bill and counter for filling out forms, like a driver's test form after an injury, not work disability related? So that's right. What Ardith is talking about. Yeah,
there still needs to be a face-to-face service for part of that. Otherwise, there's just like the 99070 for the physician services for paperwork.
Let's see. Will CMS now accept 99281 for a left without being seen patient in the ED, since 99281 no longer requires a physician or QHP? Ardith, do you know that?
Yeah, the regulations for that have not changed.
It hasn't changed. Okay.
No. So there still needs to be the physician or somebody driving the care for the patient.
So if there's no MD or QHP seeing a patient in emergency room for the lowest level, which is a 99281, who would be billing this code? So that would be whoever is billing the professional side. So if the facility also bills professional side for that, then that would be if they own the physicians there, that would be that the facility. Or do you have anything to add to that, Ardith?
Nope, that sounds right to me.
I think we can, there's a lot of questions on here, a lot of great questions.
Yeah, and so these will we will answer these and type them out, and they will be posted on the website. So
perfect.
Keep an eye out for that.
That sounds good. And so we'll stop the Q&A for now, and I'll just wrap it up. Thank you again, everyone, for joining us. A reminder that a follow-up email with the link to the presentation, the slide download, and the CEU certificates will be sent out by end of day tomorrow. If you don't receive that, please just reach out and we can make sure to get it to you. And we still have a ton of webinars coming up for the rest of the year, a lot of CEU opportunities with those as well. So you can just check the vitalware.com website and go to the webinars page to register for those. And I think that's all that we have for today. So thank you everyone for joining us, and have a great rest of your day. Thanks.